Good morning and welcome to DGSOM Annual Senior Scholarship Day. I'm Allison Diamant, co-chair of the College Chairs Committee with Ed Ha and chair of the Primary Care College. It is my sincere pleasure and honor to moderate our oral plenary session, highlighting the work of 5 outstanding students. After each presentation, we'll have time for questions. It's been a challenging year and our students have demonstrated their leadership, creativity, and commitment, and we are all so incredibly proud of them. After a break from our plenary session, we will have the next portion of Senior Scholarship Day, the poster session, and it's being presented by college. So for all of the students, just a reminder that you are required to visit at least one of your colleagues in each of the other colleges after your college has finished. Before we continue, Shamar Jones is going to go through some of the housekeeping and the overall schedule and how to navigate things for the morning. Shamar?
Good morning, everyone. Thank you, Dr. Diamant. Welcome, senior class, and welcome all of our participants. We are excited to have you here. We're excited to see all your projects and your work, and it's been an amazing time spent with you over the last 4 years. And I will just quickly go over for our participants so that we have an understanding of what will happen after the plenary session. So if you did not keep the information that was sent out of how to navigate, I'm going to go over that really quick, and then later I'll put some of that information into the chat so that you can log on later on. So let me quickly share my screen here. So I want to say first a quick thank you to a few people who are very important in making this happen, and that is all of our folks who put the work behind this site and helping with everything. And that would be in no particular order. That would be Zen Gu, Bill Holloway, Curtis Austin, Sean Stanley, Sadak Yu, Jason Rock, and Catherine Wiggin as well. So I just want to thank them for all their tremendous work in helping us get this launched today. And also to all the students for putting in the hard work and effort in making this happen. So for today, after the plenary session actually is over, what you're going to do is all of our students are going to be on this amazing site that we've put together. I will put some information in the chat so you can get here and figure out how to navigate. You can find this a couple different ways. If you go to our Senior Scholarship Day page, the best way to do, you'll be able to find the event schedule for today. We click this here. So we'll open up the schedule that we have for today. You'll see our plenary session here. You'll see a link here for the concurrent poster session. And if you scroll down here, we want to really emphasize that use this schedule to navigate for today. And you'll see that this is the order in which the students will be presented in each of their 4th-year colleges. So starting at 9:10, that will be the Applied Anatomy College. And so when you go to this site here, our Senior Scholarship Day poster site, you're going to see this page. It'll have the information here. Just come and click Senior Scholarship Day. That will open up this page here, and there are 2 views here, which is the list view, which just lists all the students who are presenting today. And then we have the poster view. And you want to navigate to the poster view. And so in this poster view, what you'll notice is use your schedule to sort of guide you. And our first group that will be presenting today, you'll see the Applied Anatomy College. If you click this tab, it's going to essentially bring up every single student that's in the Applied Anatomy College. You can now scroll down, and you will see on this page, right here, it tells you the time that they're presenting, the end time. This little tab here that says chat with presenter will actually become live right at 9:10. This will turn green or blue. And at that time, you'll be able to click. You'll be chatting with students in a personal room. So there could be several participants in that room listening to students present about their work. If you just want to peruse and search the site, you can do that. You can click here to view the student's entire poster. You can zoom in on this, you can zoom out, you can see all the features here. So this is a really great tool that we've put together. And so I would say just take advantage, visit as many students' posters as you can. We have over 195 posters that are here and presentations and abstracts. So we're looking forward to this today. And again, just remember that the next group that will present, which would be CDU, I believe, that you can check that on the schedule. Once you click this here, it will change the entire view to all the presenters that will be in the Charles R. Drew Underserved College. And again, this will light up when it's time for this particular group to present. I'll put some of this information in the chat. And after we're done here, I'll be hanging around on the webinar in case people want to ask questions or have any other troubleshooting issues that they'd like to go over. And I will now turn it back over to Dr. Diamant.
Shamar, thank you so much. We are looking forward to a very, very exciting morning. The breadth and depth of the scholarly work that our students have participated in is really quite remarkable, and we are so incredibly proud. So I encourage all of the students, all of the faculty, all of the staff and other visitors who are joining us this morning to appreciate all of the effort that the students have exhibited. To start, we have Esteban Aguayo from the Charles R. Drew Underserved College. He's going to be presenting on the impact of safety net status in cholecystostomy tube utilization in acute cholecystitis.
Moderators, faculty, and classmates, I had the distinct pleasure of starting off this year's Senior Scholarship Day. My mentor is Dr. Payman Ben-Harash, a cardiac surgeon here at UCLA. Thank you for all your guidance and support. We have no disclosures. With near universal adoption of laparoscopic methods and enhanced instrumentation, the treatment of acute cholecystitis has significantly improved over the past 3 decades. Cholecystectomy is now a common procedure with close to 300,000 surgeries performed annually. A subset of acute cholecystitis patients with severe physiological derangements or advanced burden of comorbidities continue to face 2 to 3-fold higher mortality. More recently, percutaneous cholecystostomy has emerged as a less invasive alternative to cholecystectomy and is thought to provide relief of sepsis while reducing perioperative risk. The Tokyo guidelines were devised to provide algorithmic approaches to the management based on expert consensus and available evidence. Patients with Tokyo grade 3 severity are recommended to undergo gallbladder drainage in the setting of increased comorbidities. The cholecystostomy catheter can be placed intraperitoneal, but is most commonly placed extraperitoneal via a subcostal or intercostal approach. Here's a picture of an intercostal transhepatic approach to the gallbladder. With evidence suggesting increased cost and duration of stay with cholecystostomy, the utilization of this strategy in distressed health systems is of particular importance. As we all know, safety net hospitals provide essential care to a high proportion of underinsured patients with limited resources. Given the prevalence of cholecystitis admissions, understanding the influence of hospital-level characteristics on the choice of therapy is essential. Given the potential for high resource use in patients with complicated cholecystitis, the present population-based analysis examined the utilization of cholecystostomy at safety net hospitals. Our hypothesis was that safety net hospitals would utilize percutaneous cholecystostomy at a higher rate, impacting the difference in mortality, costs, length of stay, and non-elective 30-day readmission. This was a retrospective cohort study utilizing the nationwide readmission database between 2010 to 2018 and identified patients who were admitted for acute cholecystitis. Tokyo grade 3 or severe status was assigned to patients with the presence of hypotension, acute respiratory failure, altered mental status, acute renal failure, acute and subacute hepatic failure, and low thrombocytopenia. Safety net hospitals were then classified if the percentile of under or uninsured patients exceeded 75%. Utilizing ICD-9 and ICD-10 codes, an estimated 3.6 million patients with acute cholecystitis were identified during the study period. We removed patients younger than 18 years of age and patients with concomitant diagnosis of pancreatitis, cholangitis, or reduced cholecystitis severity. Patients who were medically treated or with both cholecystectomy and cholecystostomy procedures present were also removed. Finally, we removed all patients who had missing age, mortality, and cost data. Our final population size was close to 270,000 patients. 16% of acute cholecystitis patients were treated at safety net hospitals. On average, patients treated at a safety net hospital were younger, more likely female, with no difference in the Elix-Hauser comorbidity index. Briefly, the Elix-Hauser index is a validated composite measure of 30 comorbidities. Within the composite, patients at safety net hospitals had lower rates of congestive heart failure, coronary artery disease, and chronic lung disease. There was no difference in the hospital teaching status or size within the two cohorts. Interestingly, there was no difference between the cholecystostomy utilization rate between the two cohorts, but patients at safety net hospitals had an elevated index mortality with increased length of stay, hospitalization costs, and 30-day readmission rate. These patients were also more likely to be discharged home and less likely to be discharged to a skilled nursing facility or with home health. After accounting for patient and hospital characteristics, factors associated with cholecystostomy utilization included chronic kidney disease, liver disease, teaching hospital status, and safety net hospitals, among others. Furthermore, safety net hospitals were significantly associated with index mortality, increased hospitalization costs, length of stay, and 30-day readmission. In summary, on an unadjusted comparison, only percutaneous cholecystostomy placement was not significantly different between the two cohorts. Mortality, costs, and length of stay on index admission was significantly increased for safety net hospitals. An increase in non-elective 30-day readmission was also observed. After adjustment, safety net status was strongly associated with all 5 outcomes. Increased efforts to address underlying disparities, such as access to care and resource availability, may improve care for those treated at safety net hospitals. I want to thank Dr. Ben-Harash, the Core Lab, and Charles R. Drew for all of their support.
Esteban, thank you so much for a very illuminating presentation. I have a couple questions for you. Why do you think that higher or worse outcomes were associated with teaching hospitals, and what do you think can be done to address this disparity?
Thank you so much for the question, Dr. Diamant. I think that this answer, or the reason why these patients have worse outcomes is because of the follow-up. Many of the times, these patients have to wait longer times to get their cholecystostomy tube placed in the initial setting, in the initial admission. A lot of the times these safety net hospitals, don't have in-house IR available to place these tubes in a prompt manner. And also the follow-up for these, procedures is not well studied, and there leaves a long period for mismanagement. On average, these tubes are left for 6 weeks, and patients are discharged home. And whether they come back to get their interval cholecystectomy at an appropriate time is still unknown. So in the future, I think that we can. My major want is to get more resources to these safety net institutions that provide amazing care for a lot of these patients, but don't have the necessary resources to do so. And also just to keep in mind that we can have more prompt management of these patients, and also have an interval cholecystectomy at an appropriate time.
Excellent. I have put out a question to Shamar to find out whether using the webinar, we're able to have others ask questions, and I have not received a response. So I think, Esteban, thank you again for your excellent work and scholarship, and good luck with match tomorrow and finding out where you're going to go. We will move on to our next presenter, who's going to be Orly Bell from the Primary Care College. Her presentation is Measuring Variation in Financial Stress and its Association with Social Needs in a Primary Care Pediatric Clinic. Thank you, Orly.
Thank you, Dr. Diamant. So as I get my screen set up, looks like it's all good. I just wanted to say congratulations to everybody on getting this far in medical school. So as Dr. Diamant mentioned, I'm going to be talking about my work with Dr. Adam Shikadan. And just to give a little bit of background, there's new evidence that suggests that poverty-related financial stress is the root cause of many social determinants of health and is a major mediator of poverty's effect on health and well-being. So knowing the effects poverty has on health, clinics have started to use screening tools to screen individuals for things like food and housing insecurity and link individuals to services to address these needs in the community. But patients who report having difficulty affording these basic needs are already in a state of financial crisis. And knowing that the social needs are downstream effects of poverty, it may actually be more useful to target poverty more directly instead of focusing on individual social needs. But there hasn't been a lot of published data on whether patients are interested in receiving these types of connection to services in the clinical space. So this is where our study comes in. We asked the question, does measuring financial stress predict which families have social needs and or interest in social services, and what can we do about it? Between June and September of 2018, we conducted a cross-sectional survey of parents and caregivers of pediatric patients at Harbor UCLA Pediatrics Primary Care Clinic. We asked questions to assess perceived financial stress using the Federal Consumer Financial Protection Bureau's Financial Wellbeing Scale, try saying that 5 times fast, and split our population into 3 groups: low, medium, and high financial stress. We also asked them how difficult it was for them to afford social needs such as food, rent, and also asked if they would be interested in receiving a connection to social needs services as well as financial services in the clinic. We performed univariate, bivariate, and multivariate regression analyses. In the multivariate analyses, we use linear and Firth logistic regression models, and we adjusted for the patient characteristics that are listed in the slide. We looked at associations between the perceived financial stress and difficulty affording social needs and interest in services to address these needs. Here are some of the key demographics of those who completed the questionnaire. And for the key outcome variables, 91% of the population reported a high degree of difficulty affording any social need, and 53% were interested in receiving services to address these needs. On the right-hand side of the slide, you can see that we found a high degree of variation in the CFPB financial well-being scale distribution in this primarily low-income Medicaid managed care or enrolled population. Here we see that there's a dose-response relationship between perceived financial stress and difficulty affording social needs, with individuals in the highest financial stress group, the gold bar graph, reporting the greatest difficulty affording social needs. For interest in services, we found that people with the highest perceived financial stress had the highest level of interest across the board for all services, followed by those in the medium financial stress group, and then by those in the low financial stress group. So our data showed that there was a high degree of variation in financial stress in this uniformly Medicaid enrolled or eligible group. Those in the highest financial stress group were a lot more likely to express greater difficulty affording social needs and also express interest in having co-location of services in the clinic to help ameliorate this stress. This suggests that clinics can use the CFPB financial well-being scale to measure financial stress as a way to identify individuals who may benefit from connection to social services in the clinic. Our results also suggest that there is interest among patient families to create interventions that are focused on alleviating financial stress directly. Based on the findings of the study, we postulated that perhaps we should be addressing financial stress directly in the clinic. And to go about doing this, we established a medical financial partnership at Harbor UCLA Pediatrics Clinic. Medical financial partnerships are anti-poverty-based interventions that are partnerships between financial service organizations and health systems. This model is similar to that of the medical legal partnerships, which you may be familiar with, in that they co-locate services to reduce logistical barriers and avoid waiting times to access community-based services. They also operate in a space of already established trust between patients and providers or clinics. And medical financial partnerships currently exist nationwide in both the pediatric and adult primary care clinics. And they've been found to improve overall subjective health status, as well as increased family financial well-being. Numerous studies have also shown that they're desired by both patients and providers. The medical financial partnership at Harbor UCLA is currently providing one-on-one financial coaching to patient families, and that's also providing warm handoff to services out in the community. We're currently studying the impact of this medical financial partnership and are continuing to expand to DHS sites. So I just want to take a moment to say a huge thank you to Dr. Adam Shikadans for really being the most outstanding mentor to me throughout medical school. And a huge thank you to Olivia Wu for collecting this data and the amazing leadership and staff at Harbor UCLA Pediatrics Clinic, who without them, this work would not be possible. And thanks so much to the primary care college chairs for allowing me to share this work with you today.
Orly, thank you so much for a really exciting project. For anybody, if you want to put your questions in the Q&A function, we'll be monitoring it so that we can ask that of our speakers. Orly, what do you think the next steps are in terms of being able to disseminate something like this to perhaps not as large a clinic as Harbor, but maybe some of the community clinics either in LA or around the country?
I think it's, thank you for that question, Dr. Diamant. I think that really the biggest thing is to have steps that clinics can follow in order to implement this, because it can be done on a small scale as well as a large scale. All you need is provider and leadership who will be willing to take on this kind of partnership. And Dr. Shikadans and I are actually working on an implementation project to kind of show how this could be implemented in many different settings. And we hope that many places will take on this idea.
Excellent, great, that's great. Thank you so much again. Are there any questions? I don't see anything so far. Orly, thank you so much again and congratulations. We will be moving on to our next presenter, representing the Academic Medicine College, Swan Tran. She'll be speaking to us about the functional connectivity during language processing in infants at familial risk for autism spectrum disorder. Welcome, Swan.
Thank you, Dr. Diamant. Let me set up my screen. Can everyone see the screen? Great. Good morning, everyone. Today, I'm honored to represent the Academic Medicine College, and I'm very excited to share with you a portion of my PhD research examining brain network connectivity and autism, conducted under the mentorship of Dr. Shefali Jeste. Autism spectrum disorder is defined behaviorally based on impairment in social communication skills and patterns of restricted and repetitive behaviors and interests. While it is diagnosed clinically at 3 years of age, some children may show earlier behavioral signs of ASD after the first year of life. From genetic studies of ASD, we know that brain networks are affected much earlier on during fetal development. In our lab, we use EEG to study brain networks in familial risk infants. These infants are defined as having at least one older sibling with ASD. Compared to the 2% rate of ASD in the general population, up to 20% of familial risk infants can develop ASD, while another 30% can develop other neurodevelopmental delays, such as broader autism phenotype or language delay. We can use EEG as a non-invasive tool to study brain development and identify early red flags during infancy, such that infants with altered trajectories in brain development can be directed towards early behavioral interventions and better outcomes. Just as a general background, the EEG signal that we measure can be analyzed in different frequency bands. We are particularly interested in theta and alpha frequency band, as you can see here on the graph, which are robust in early infancy. Within a frequency band, phase coherence is the correlation in phase between two electrodes signals, as you can see here on these figures. Regions with greater phase coherence can then be inferred to have greater functional connectivity. So from hence now onwards, when I say coherence, you can think of it as connectivity. The overarching goal of this study is to measure neural network changes during language processing at 3 months of age in infants at familial risk for ASD. This is our study design. At 3 months of age, the EEG was collected during an auditory language processing task in which infants listened to a continuous stream of syllables containing 4 different trisyllabic pseudo words. Infants were also watching some moving subbubbles on a computer screen during this task in order to stay calm. At 18 months of age, ASD symptoms were assessed using the Autism Diagnostic Observation Scale toddler module, also known as the ADOS-T. Subjects with elevated scores on this assessment were placed in the ASD concern group, and the remaining subjects were placed in the no ASD concern group. We then compared differences in phase coherence in language networks between the ASD concern and the no ASD concern groups. And this is my study sample. Our study sample consisted of familial risk and low risk infants who were recruited at 3 months of age and then divided into ASD concern and no ASD concern groups based on their ASD symptoms at 18 months of age. We found that at 3 months of age, the ASD concern group had much lower phase coherence, as you can see here in the orange bar, compared to the no ASD concern group, seen here in teal, in both theta and alpha frequency bands, specifically at the left frontal central electrode pair. I also want to draw your attention here to the group distribution. The ASD concern group was tightly clustered together, while the no ASD concern group had a greater range in coherence values. And infants with very high coherence values went on to have typical development, regardless of their original familial risk status. We also found that coherence at 3 months of age positively correlated with the subject's word production at 18 months of age, such that infants with higher connectivity went on to have larger vocabulary at 18 months. So in conclusion, our study demonstrated that neural network changes during language processing is detectable at 3 months of age. Our data also suggests that there may be a protective threshold in connectivity during infancy, in which may promote typical language development. I'm very excited to show you some ongoing work in the lab, which includes first replication of this baby infant study in a much larger nationwide cohort. And second, inclusion of infants with genetic syndromes such as tuberous sclerosis complex and 22q deletion syndrome. It is our biggest hope that one day we can bring this type of EEG research to the clinic in order to help guide early detection and early intervention for children at risk of ASD. Thank you so much for your attention, and I'm happy to answer any question you may have.
Dawn, thank you so much for an excellent presentation. There are some questions in the chat, so I will read those to you. One from Carlos Portera Cayul. Do you think facial expressions in toddlers could be used in conjunction with EEG to help improve its predictive power, perhaps applying machine learning algorithms to high-res videos of the face?
I think definitely looking at the child's because with nonverbal communication, part of it is your facial expression. So I definitely see that can be incorporated in the future. We are already using eye tracking as well together with EEG.
Excellent. And from Hero Sparks, how do you choose your electrodes?
Yes. So this was based on prior literature in infancy, using EEG to study language networks during various language tasks. So I picked the frontal and central temporal electrodes based on those prior studies. And if you email me afterwards, I'll be happy to share my sources.
And I had a question, and it may be outside the range of the study, so feel free to say that the information's not available. But does it matter how old or the number of siblings that an infant may have who may be on the ASD spectrum in terms of their own risk or predictive?
Oh, yes, definitely. So if the child has one older sibling with autism, the infant's risk goes from 2% to 20%, like I said earlier. If they have two siblings with known diagnosis of autism, their own risk go up to 50% of developing autism. So we see a high genetic and inherent rate of autism within family with multiple children with autism.
Excellent. Thank you so much, Swan, for a really fascinating presentation, and congratulations on your PhD work.
Thank you so much, Dr. Damon.
Our next presenter is Brian Zukotinsky from the Applied Anatomy College. Brian's going to be talking to us about virtual reality, a future tool for surgical education.
Great. Hello, good morning, everybody. Thank you for coming to attend this talk virtually. I'm going to be talking about another virtual technology, as well as congratulations to everyone. Hoping for good news in 24 hours and 28 minutes. All right. So first of all, I personally have no disclosures, but a couple of my senior authors do. You can view them on the AOS website. So current struggles of surgical residency, as time has gone on, there's been an increased number and complexity of procedures, but as well as an increased amount of time having to be spent on administrative tasks, as well as legal requirements for increased supervision by an attending. So that has led to kind of a shortage of residents feeling more comfortable with procedures by the end of their residency. Current procedural learning methods, at least in orthopedics, have included reading, especially from orthobullets.com, as well as surgical technique guides, as well as residents have become more familiar with their procedures, as well as sawbone simulations and cadaveric simulations. But really none are a true replacement for supervised guided operative experience with an expert attending. So the goal is to find some kind of method that will allow residents to take better advantage of the nuance that can be offered during their time with the attending. Enter virtual reality as a possible teaching tool. Benefits are that it allows unlimited repetitions, as well as structured training programs with real-time feedback and even post-procedure assessments. They've already been used and been demonstrated effectiveness as warm-ups for practicing surgeons and are currently widely used in general surgery, but only now are starting to become popular in orthopedic surgery. With this in mind, we endeavored to see if VR could enhance the learning of novice medical students when performing a sawbone simulated tibial intramedullary nail fixation, which is one of the most commonly performed orthopedic procedures and is really one of the fundamentals for juniors to master. Most notably in the news recently, it was one of the surgeries performed on Tiger Woods at our own Harbor UCLA. When performed correctly, tibial intramedullary nail fixation really restores alignment, stabilizes the fracture, and allows for immediate weight bearing. However, failures to perform all of the steps correctly can lead to increased risk of iatrogenic injury to blood vessels and nerves, and long-term sequelae, including non-union, malunion, and infection. So our experiment involved recruiting 20 novice medical students and randomizing them into two groups. 10 of them were going to do the virtual reality training platform, and 10 of them were going to study a standardized surgical technique guide, each for 20 minutes. After 20 minutes of intense simulation or study, the students were brought into another room and set loose on a set of real surgical tools. During the procedures, they were assessed by an attending surgeon for operative technique, number of steps completed correctly, as well as timing. Here's an example of the real setup that we used in our experiment, pulling real surgical instruments, as well as a drill from Home Depot. Some of the attempts resulted in success. Others of them resulted in confusion, sometimes failure. But luckily, the attending surgeon was available to step in before any frustrations got too much. So our blinded attending observer was using a global assessment rating scale and was going to be rating the subject, novice medical students, on areas such as time and motion, instrument handling, knowledge of instruments, flow of the operation and forward planning, as well as knowledge of the specific procedure. And each subject was given a rating scale from 1 to 5, with 5 being the best score. We also had a procedure-specific checklist, which kind of a simplified procedure for this tibial nail as the subjects performed them on the sawbones. So as far as our results, VR here is in orange, and the control group with the surgical technique guide are in blue. There's a significant difference on pretty much every measure of the global assessments rating scale in every area with VR training. And as far as some interesting data points for the procedure-specific checklist, you'll see here that VR was significantly better at the middle steps, nail insertion and proximal interlock guides, as well as nail assembly, whereas there was not too much a difference at the beginning steps as well as the last step of the procedure. So as far as discussion of things that we can talk about for the results, just as a point of information, the novice medical students were chosen and kind of screened for any prior exposure to the procedure, as well as given a drill training at the start so that all medical students knew how to use a drill before the procedure testing portion. And we saw that short-term training with VR significantly increased their surgical performance in the global assessment scores in all 5 areas that you can see here. And there weren't any significant differences in the completion of the first 3 steps of the procedure-specific checklist. However, there was a significant difference for the VR group who were able to complete more of the complex middle steps of the procedure that included, as you saw from the checklist over here, kind of the nail assembly, the whole complex jig, as well as putting the proximal interlock guides which has different sleeves that you're supposed to use. As far as next steps and future questions, one thing we want to ask is skill acquisition translatable. So are we able to use VR does training with VR increase trainees' ability to learn multiple procedures at once? And really the key question is, can people be taught to teach themselves? Because this really raises the point that skill acquisition in and of itself is a skill. And different trainees come in at different levels depending on their previous background or natural ability. And so being able to help everyone learn more efficiently would allow for better surgical resident training. And then one thing to test in the future, definitely to point out, is that just simply the visualization component, but testing VR versus watching a video demonstration compared to doing a surgical technique guide. And I'd like to give special thanks to the Bernthal Lab. Here's our picture from Lab Retreat. Dr. Bernthal has been a great mentor, my 4 years of medical school, as well as Dr. Suhu. So yes, thank you everyone. Happy to take any questions.
Excellent. Brian, thank you so much. Very, very interesting, especially building on the combined surgical grand rounds from yesterday in terms of the ability to better train and monitor how well we're preparing our surgeons. We do have a couple of questions. One question was, how was the 20-minute pre-assessment time selected?
Yeah, so I think 20 minutes was kind of honed in as kind of a selection of how much time can we realistically do and realistically test in a day, as well as testing one of the other components of virtual reality of doing really like rapid learning. So does it increase the learning speed as well?
Excellent. Another question from Dr. DiVirgilio. Great job. Do you envision VR training could be transformative and used as a way of supplementing training of orthopedic surgeons in low-income countries in a remote fashion, perhaps by US surgeons?
Yeah, that is a really good question. This platform, one of its pitching points was that it is kind of allows for cheaper training because you can do unlimited repetitions, and actually like getting that exposure. One possible option would be to have, say, a US expert surgeon kind of strap on a headset, and you could try to like zoom in or zoom in live and get a whole like feel for the whole operating in like a high fidelity kind of feel of shadowing or experiencing. So that's definitely a possibility. But at the same time, nothing's really going to replace that in-person teaching component. And so really what VR is going to do is try to get those basic steps of what are the steps of the procedure and like how is the operating room laid out and how are your tools laid out, so that when the resident comes into the operating room, they're better able to take advantage of the more nuanced points that the attending or the expert is giving.
Two more quick questions. One, do surgeon biases have the potential to impact these results?
Of course, bias is always possible. For our attending observer, they were blinded as to what was the training of the medical students that went in and performed the Soblins procedure for them.
Okay, and last question from Dr. Sridhar. What is the cost of development of such applications? And that would determine the comparison between traditional learning and these new methods.
Yeah, so cost of development has really been a big point. There have been, in orthopedics especially, there's been a push for like really trying to go for like high fidelity arthroscopic simulators that can cost upwards of 5 figures and whatnot. The nice thing about this platform was it's built on just the Oculus Rift platform. And while it doesn't have that same kind of tactile feedback, its goal really is targeting acquisition of just like the basic steps of the procedure, because at least in some people's opinion, I feel that getting the nuanced feel of how the tissue actually works and everything is something that's better suited for the OR, but then you're better able to learn those, better able to grasp those things when you're not having to worry about memorizing the steps of the procedure because you've already done this training with the virtual reality platform.
Well, lots of different technologies are expanding training opportunities to enhance quality and outcomes, which is very exciting. Brian, thank you so much.
Great. Thank you.
The last presenter is Verena Clark from the Acute Care College. She's going to be presenting on in vivo knockdown of SNAI1 is a novel therapeutic strategy for pulmonary hypertension-induced right ventricular failure. Welcome, Verena.
Hi, all. Can you hear me okay? Thank you so much for having me today. Unfortunately, I did have some technical issues, so Shamar Jones will be advancing my slides for me today. So thank you so much, Shamar.
You're welcome, Verena.
Congrats to all my classmates. We did it in the pandemic. I'm really excited for us. So as we load this up, I just want to give a special thanks to my PI and mentor, Dr. Soban Umar, and I'll get started. Next slide, please. Next. Pulmonary hypertension is a debilitating and incurable disease characterized by right ventricular hypertrophy, right ventricular failure, arrhythmias, and sudden death. In the vast majority of idiopathic pulmonary hypertension patients, the RV compensatory response is insufficient. Advanced cases of pulmonary hypertension often lead to invasive procedures such as lung and/or heart transplant. And even with current therapies, the prognosis of pulmonary hypertension is poor. Next. Thus, RV function is a major determinant of functional capacity and prognosis. The main cause of death in patients with pulmonary hypertension is RV failure. Next. Endothelial to mesenchymal transition, also known as ENDMT, has been previously identified in cancer literature as a process whereby endothelium acquires a mesenchymal phenotype in response to stress or insults such as pulmonary hypertension. Next. However, there's paucity of information on the exact molecular mechanism of ENDMT in the RV. Next. Thus, targeting ENDMT in the RV and identifying clinically relevant prognostic predictors may hold therapeutic promise for our patients with pulmonary hypertension and cardiopulmonary disease. Next. As shown on the right with transcriptomic analysis of the right ventricles of both monocrotaline or MCT and Sugen hypoxia models, which are well-known animal models to pulmonary hypertension, we identified epithelial to mesenchymal or endothelial to mesenchymal, also known as ENDMT, as a top upregulated pathway. Next. Next. In our experimental model, we had 3 groups of adult male Sprague Dawley rats, each with an N of 4 that would follow for 30 days. The rats were exposed to either a subcutaneous injection of PBS serving as controls, or MCT, or Sugen hypoxia. In the top panel, we show double immunolabeling of RV tissue with both endothelial and mesenchymal markers. As indicated by the white arrows, in comparison to control, the MCT and Sugen hypoxia rats exhibit co-localization of both markers, which demonstrate evidence of ENDMT in the setting of pulmonary hypertension. In the bottom panel, pulmonary hypertension models also exhibited significant interstitial fibrosis, highlighted in blue with trichrome staining. Next. Next, we obtained human RV tissue from 7 patients who had RV failure and 3 controls. Similarly to the animal models, there were marker co-localization, further confirming ENDMT and substantial fibrosis in the setting of pulmonary hypertension-associated RV failure. Next slide. Next, previous studies have identified core regulators of ENDMT that are involved in cardiac disease and cancer progression. Next. Of these factors, SNI1 has been shown to have a predominant role in ENDMT. Thus, investigating SNI1 may lead to the development of new targeted therapies for pulmonary hypertension-associated RV failure. Next, as shown in our network analysis, next, and RNA sequencing, next. SNI1 has been shown to have a predominant role in ENDMT with approximately 2-fold increase in both MCT and Sugen hypoxia rats. Next. Following up with human RV tissues, the black arrows indicate activation and nuclear localization of SNI1, which was not observed in our control patients. Next. Next slide. We propose the following mechanism for SNI1-induced ENDMT supported by RNA sequencing data. In the setting of pulmonary hypertension, where there's increased vascular load and subsequent adverse structural remodeling, the RV endothelium, which initially only expresses endothelial markers, next, undergoes significant stress and RV overload, causing activation of TGF-beta1, which eventually activates SNI. Activated SNI1 causes a cascade of molecular events leading to chromatin reorganization and ultimately, next, acquisition of a mesenchymal phenotype. Next. Thus, our hypothesis is that SNI1 and its network of genes play a key role in mediating ENDMT and are significantly regulated in the RV in severe pulmonary hypertension. Next slide. To test our hypothesis, we performed in vivo SNI1 knockdown using small interfering RNA or siRNA to see if we could rescue the RV. We first administered subcutaneous MCT to 13 rats, which we divided into 2 groups. At day 14, siRNA was given to 6 rats and scramble or sham was given to 7 rats via tail vein injection. Next. Here in the middle panel, we confirmed the presence of ENDMT and collected terminal heart and lung tissue. We found that in siRNA-treated rats in the right panel, there was less RV dilatation and improved hypertrophy of RV-free wall and RV septum. We also found less RV fibrosis and less vascularized lung arterioles. Next. As shown in panel C, to assess RV function, we use right heart catheterization to measure RV systolic pressure, RV fractional area change, and RV hypertrophy, All parameters were significantly decreased when compared to control. Next. Lastly, using PCR to confirm SNI1 gene expression, siRNA-treated rats had significantly decreased SNI1 expression in the RV with no significant change in the lungs. This illustrates that our knockdown of SNI1 was specific to the RV. Next. Taken together, knockdown of SNI1 with siRNA caused improved RV function and rescue of the RV. Next slide. In conclusion, severe pulmonary hypertension is associated with RV pressure overload, hypertrophy, and dysfunction. NMT is one of the top upregulated pathways in RV failure, with SNI1 as a key transcription factor. And we will continue to explore and refine these molecular pathways. And for patients suffering from pulmonary hypertension-induced RV failure, targeting SNI1 and its network may lead to the development of novel, targeted, and effective therapies. Next. So thank you all for your time, and a special thanks to my mentor, Dr. Umar and the Umar Lab, Dr. Nguyen Lee, Dr. Diamant, and Shamar for their mentorship, and thank you DGSOM for supporting me throughout this entire journey. I'll take questions at this time.
So, Verena, thank you so much. Very, very fascinating. So a quick question. You mentioned the opportunity to develop novel therapies. Is there anything that you know of that's currently in the works? Because pulmonary hypertension is so very difficult to treat.
Yeah, that's a great question. Thank you.
Transplant?
Yeah, so in terms of the treatments for pulmonary hypertension, none of them are targeted. And so there are some treatments that can, symptomatically help patients, especially given, the high risk of transplant required. But in terms of targeted therapies to the RV, we have not yet seen it. And so we're hoping that these studies and this data can help to promote that. But there has been some talk again in the LV as well, but considering the fact that pulmonary hypertension really does affect that RV, we're looking for that targeted approach for sure. I think you're on mute.
I am on mute, trying to drown out the street noise. Any questions at all for Verena? You can post it in the Q&A or in the chat. I guess depending on where you match will depend on whether you're able to continue this work. Is this something that you see yourself pursuing in the future?
Yes, as a future anesthesiologist, yes, I'm very interested in this work, especially since it affects the patients that I'll be working with. Dr. Umar has been a great mentor, and I hope to continue to work with him and also to expand this to look at other things such as, the risks in male versus female rats and really hone in on the development of that molecular pathway. So I'm really excited to continue this work. And thank you again. In the future, I will be presenting at the ASA national meeting to talk more about the final results of this study. So join me there.
Excellent. Well, Dr. Umar is very proud of you and posted that in the Q&A, as did many other people.
Thank you so much.
Thank you so much to all of our presenters on their great, great work, truly demonstrating some of the best of our class of students. Please enjoy the poster session. I know that some of the information that Shamar provided to us was a little complex, but before we break, I'm gonna hand it over to Dr. Miller.
Hey, thank you so much, Dr. Diamant. And those were superb presentations. Congratulations to all 5 of you, and really to all of you for the work that are so incredibly excited about tomorrow. In just a little bit this morning, you'll be receiving by email some detailed instructions for navigating the Zoom room tomorrow. And it's really important that you read over those so that we can have as great a time together as possible. And it will be flipping between different Zoom views and camera on, camera off, those kinds of things. If you have any questions, reach out to me or Jason today. Before we break and go into different rooms, I just want to mention that each year the U.S. Public Health Service recognizes one medical student at each medical school for excellence in public health. And so I'm going to pass the baton to Dr. Elizabeth from the U.S. Public Health Service. Hi there, Elizabeth.
Hi, good morning, everybody.
And to share with us The news for this year's recipient. On to you, Elizabeth.
Thank you. Well, good morning, everyone. My name is Lieutenant Commander Elizabeth Van Dyne, and I'm a medical officer with the U.S. Public Health Service Commission Corps. Prior to this, I was a pediatric hematology oncology fellow at UCLA, so it's great to see everyone, and congratulations to everyone. So I am here on behalf of the Surgeon General of the United States to recognize an outstanding student from UCLA who has been selected to receive the 2021 Excellence in Public Health Award. The Public Health Service was founded in 1798 to provide medical care to sailors and merchant seamen with yellow fever and malaria. Over the subsequent 220 years, our mission has broadened to deliver health promotion and disease prevention programs to all people. Today, the Commission Corps of the Public Health Service is dedicated to serving on the front lines in the nation's fight against disease and poor health conditions. On behalf of the U.S. Public Health Service, I would like to recognize Beatrice Marone with the 2021 Excellence in Public Health Award. Congratulations. Thank you for your hard work and dedication to public health, and we hope you consider a career with the U.S. Public Health Service. Congratulations, Beatrice, and congratulations, everyone.
Thank you so much, Dr. Van Dyne. And Beatrice, are you there? Did we?
Yes, Beatrice, if you're there, unmute yourself.
Hi, yes, good morning. What a nice surprise. Was not expecting that this morning, but thank you so much for the recognition.
Congratulations.
Yeah,
So proud of you, Beatrice. Congrats.
thank you.
All right. Dr. Diamant and Shamar, any last words before we break into different areas?
Just thank you, everybody, again. It really does show the strength of our student classes. These were 5 outstanding presentations, but the decisions to highlight these students' work were extremely difficult. We have fantastic work that's been done across the spectrum of scholarship from all of our students in all of our colleges. So I really encourage everybody to take advantage of what our students have been doing and to be inspired by them, as I always am.
Thanks, everybody. I will hang around here for a little while. So if anyone has questions or they want to pop into the chat, I'll be sitting here for a little bit and then get an opportunity to go over to the poster site and hopefully enjoy some presentations myself. But thank you, everyone. Please send questions or email. I'll have my email open now so it doesn't make any noise. But let me know if you have questions or if there's things that we can fix. And we'll see you on the other side. Thank you so much.
Great work, Shamar.
Thanks, Lee. It was great to see you. How are you?
Yeah, that went great.
It was awesome. Dr.
You
Diamant,
guys
I
did
told you.
such a terrific job.
I told you it'd be awesome. Brian, great talk.
All of the
us.
students.
Thank you. Oh, we got them.
And Beatrice, congratulations. Such great work.
Beatrice, were you wondering why all of a sudden your field got changed?
Yeah, sorry, I'm having trouble unmuting. I don't know what's going on with my
We
thing,
hear
but
you. We
Yeah,
hear
You're there.
I was surprised. I was not expecting that this morning, but it was a nice surprise. Yeah, thank you so much for
Really, so well deserved. Really phenomenal.
Yeah, thank you.
And to all of you guys, you did such great work presenting. Thank you so much.